Intestinal obstruction.
Introduction. Intestinal obstruction is an interruption in the normal flow of intestinal contents along the intestinal tract. The block may occur in the small or large intestine, may be complete or incomplete, may be mechanical or paralytic, and may or may not compromise the vascular supply.
Definition.
Bowel obstruction, also known as intestinal obstruction, is a mechanical or functional obstruction of the intestines which prevents the normal movement of the products of digestion. Intestinal obstruction is significant mechanical or paralytic impairment or complete arrest of the passage of contents through the intestine due to pathology that causes blockage of the bowel. Symptoms include cramping pain, vomiting, obstipation, and lack of flatus.
Processes of intestinal obstruction.
Two types of processes can impede this flow. Mechanical obstruction, an intraluminal obstruction or amoral obstruction from pressure on the intestinal walls occurs. Examples are foreign body, intersusception, polypotumors and neoplasms, stenosis, strictures, adhesions, hernias, and abscesses. Functional obstruction, the intestinal musculature cannot propel the contents along the bowel. Examples are amyloidosis, muscular dystrophy, endocrine disorders such as diabetes mellitus, or neurologic disorders such as Parkinson's disease. The blockage also can be temporary and the result of the manipulation of the bowel during surgery.
Risk factors. Diseases and conditions that can increase risk of intestinal obstruction include abdominal or pelvic surgery, which often causes adhesions. Crohn's disease.
Cancer within abdomen, especially if there is a surgery to remove an abdominal tumor or radiation therapy. Causes. Small bowel obstruction. A bright abdominal X-ray demonstrating a small bowel obstruction. Note multiple air fluid levels. Causes of small bowel obstruction include adhesions from previous abdominal surgery, most common cause. Barbed sutures. Pseudoobstruction. Hernias containing bowel. Crohn's disease causing adhesions or inflammatory strictures. Neoplasms, benign or malignant. Intersusception. Volvulus. Superior mesenteric artery syndrome, a compression of the duodenum by the superior mesenteric artery and the abdominal aorta. Ischemic strictures. Foreign bodies, e.g. gallstones in gallstone ileus, swallowed objects such as expandable water toss. Intestinal atresia. After abdominal surgery, the incidence of small bowel obstruction from any cause is 9%. In those where the cause of the obstruction was clear, adhesions are the single most common cause, more than half. Large bowel obstruction. A bright abdominal X-ray of a person with a large bowel obstruction showing multiple air fluid levels and dilated loops of bowel. Causes of large bowel obstruction include neoplasms, cancer, diverticulitis, diverticulosis, hernias, inflammatory bowel disease, colonic volvulus, sigmoid, cecal, transverse colon, adhesions, constipation, fecal impaction, fecaloma, colon atresia, intestinal pseudoobstruction, endometriosis, narcotic-induced, especially with the large doses given to cancer or palliative care patients. Outlet obstruction. Outlet obstruction is a subtype of large bowel obstruction and refers to conditions affecting the anorectal region that obstruct defecation, specifically conditions of the pelvic floor and anal sphincters. Outlet obstruction can be classified into 4 groups. Functional outlet obstruction. Inefficient inhibition of the internal anal sphincter. Short segment Hirschsprung's disease. Chagas disease. Hereditary internal sphincter myopathy. Inefficient relaxation of the striated pelvic floor muscles. Anismus, pelvic floor dyssynergia. Multiple sclerosis. Spinal cord lesions. Mechanical outlet obstruction. Internal intersusception. Enterosal. Dissipation of force vector. Rectosal. Descending perineum. Rectal prolapse. Impaired rectal sensitivity. Megarectum. Rectal hyposensitivity. Pathophysiology.
Clinical manifestations.
Abdominal distension. Abdominal fullness, gas. Abdominal pain and cramping. Breed odor. Constipation. Diarrhea. Vomiting. Fever. Peritoneal irritation. Increased WBC count. Toxicity. And shock may develop with all types of intestinal obstruction.
Diagnostic evaluation.
History taking.
Physical exam. Fecal material aspiration from NG tube. Abdominal and chest X-rays. May show presence and location of small or large intestinal distension, gas, or fluid. Birdbeak lesion in colonic volvulus. Foreign body visualization. Contrast studies. Barium enema may diagnose colon obstruction or intersusception. Ileus may be identified by oral barium or gastrographin. Laboratory tests may show decreased sodium, potassium, and chloride levels due to vomiting. Elevated WBC counts due to inflammation, marked increase with necrosis, strangulation, or peritonitis. Serum amylase may be elevated from irritation of the pancreas by the bowel loop. Flexible sigmoidoscopy or colonoscopy may identify the source of the obstruction, such as tumor or stricture. Imaging studies.
CT scan, MRI scan, and contrast X-ray can be used to visualize the obstruction.
Management. Medical management. Surgical management. Medical management. Correction of fluid and electrolyte imbalances with normal saline or Ringer's solution with potassium as required. NG suction to decompress bowel. TPN may be necessary to correct protein deficiency from chronic obstruction, paralytic ileus, or infection. Analgesics and sedatives, avoiding opiates due to GI motility inhibition. Antibiotics to prevent or treat infection. Ambulation for patients with paralytic ileus to encourage return of peristalsis. Surgical management consists of relieving obstruction. Options include closed bowel procedures, lysis of adhesions, reduction of volvulus, intersusception, or incarcerated hernia. Enterotomy for removal of foreign bodies. Resection of bowel for obstructing lesions, or strangulated bowel with end-to-end anastomosis. Intestinal bypass around obstruction. Temporary ostomy may be indicated. Nursing management. Nursing assessment. Assess the nature and location of the patient's pain, the presence or absence of distension, flatus, defecation, emesis, obstipation. Listen for high-pitched bowel sounds, peristaltic rushes, or absence of bowel sounds. Assess vital signs. Nursing diagnoses. Acute pain related to obstruction, distension, and strangulation. Risk for deficient fluid volume related to impaired fluid intake, vomiting, and diarrhea from intestinal obstruction. Diarrhea related to obstruction. Ineffective breathing pattern related to abdominal distension, interfering with normal lung expansion. Risk for injury related to complications and severity of illness. Fear related to life-threatening symptoms of intestinal obstruction. Nursing interventions. Achieving pain relief. Administer prescribed analgesics. Provide supportive care during NG intubation to assist with discomfort. To relieve air fluid lock syndrome, turn the patient from supine to prone position every 10 minutes until enough flatus is passed to decompress the abdomen. A rectal tube may be indicated. Maintaining electrolyte and fluid balance. Measure and record all intake and output. Administer IV fluids and parenteral nutrition as prescribed. Monitor electrolytes, urinalysis, hemoglobin, and blood cell counts, and report any abnormalities. Monitor urine output to assess renal function and to detect urine retention due to bladder compressions by the distended intestine. Monitor vital signs. A drop in BP may indicate decreased circulatory volume due to blood loss from strangulated hernia. Maintaining normal bowel elimination. Collect stool samples to test for occult blood if ordered. Maintain adequate fluid balance. Record amount and consistency of stools. Maintain NG tube as prescribed to decompress bowel. Maintaining proper lung ventilation. Keep the patient in Fowler's position to promote ventilation and relieve abdominal distension. Monitor ABG levels for oxygenation levels if ordered. Preventing injury due to complications. Prevent infarction by carefully assessing the patient's status. Pain that increases in intensity or becomes localized or continuous may herald strangulation. Detect early signs of peritonitis to minimize this complication. Avoid enemas, which may distort an X-ray or make a partial obstruction worse. Observe for signs of shock. Watch for signs of metabolic alkalosis and metabolic acidosis. Complications. Dehydration due to loss of water, sodium, and chloride. Peritonitis. Shock due to loss of electrolytes and dehydration. Death due to shock.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.